Testing 1 2. Testing 1 2.
Fix it. Yeah. So right now we're doing 95% imaging here. So I mean, I'm all OCT except osteal rights. Other than that, I OCT all the time. But everybody's using either IVIS or OCT. It's really good. It's all algorithmic, basically,
That's
before and
brilliant.
after. So not RAS.
Right. Hello, can you hear me?
Perfect.
Ah, you're okay. Thank you.
Sorry. What did I do wrong? So you're mostly radial?
Yeah, so
95% femoral.
I mean, as long as you do whatever you do well, it's fine either way, I think, yeah?
Yep.
Yeah, I was trained predominantly radial in the UK because, you know, obviously, like, I suppose I've been doing radial there predominantly for about 20 years.
Really?
But I still use, for the CTOs, you still need to use the femoral in a reasonable proportion of the cases, but I'm probably about 70-30, I think.
So, I mean, in this case, I'm a 6 French, but frequently I'm 7 because with imaging, you find out that diagonals, OMs, everything's a bifurcation.
Yeah.
So I do 7 French, and I do all my own perks, all my own closures.
Yeah. I think that's right. I think as long as you're attentive, it doesn't matter. I think that's really the message, isn't it?
And I just find, I don't care how good the radials are, with all due respect.
Airfly thing, so I'm going to try to say the worst.
I'll
hear me, guys?
wink at you. Yeah.
Jeff, you hear us?
How's the audio?
Audio's
I
good
hear
on
you,
my end.
Jeff. It sounds, I hear you clearly.
So, Margaret, what's the
Anyway.
best way to pronounce your name?
It doesn't matter, but McIntyre if it comes out right, but otherwise don't worry.
There we go. I just wanted to double. We were just discussing it.
Yeah, McIntyre. Imagine you're
We gotta have
Scottish.
respect for the culture.
Well, I know how to say McAllen.
There you go.
So, you know, I always shoot before, make sure I'm in the sweet zone, so I perk myself.
Yeah.
And to me,
That's
no, they switched it. It's on the audio. It's on the TV settings. So anyway, I find when people do radio, present company potentially excluded, everybody compromises.
Yeah.
Oh, I'm not going to do a pigtail. Oh,
Yeah.
I'm good enough for this and this and that. We do a lot of atherectomy. We do a lot of calcified complex.
Yeah.
I want to take care of that vessel. I
Yeah.
want security. I want to be confident. I don't want to be
Just focus
spending
on
an
the
hour
coronary.
trying to get my guide position.
Yeah, I
And
understand
that's like
that.
fellows are perking.
Testing.
We're perking. I've done
Yeah.
over 120,000
Testing.
perks.
Yeah.
I'm just going femoral.
Yeah. Yeah.
Can you hear us, Sarah?
Oh yeah, we hear,
So-
and I'm enjoying the conversation.
Oh, I was just explaining to my colleague.
It's all about doing things
all about-
well.
it's all
Whatever
about the
way you do
groin.
them, just do them
I
well.
always thought you do distal ulnar as your primary.
I always say the way to a man's heart is through his groin.
Quite fitting for the
Rich. He's just one.
Tell me when we start recording, so I'll shut up.
It's digital, and we can edit anything out, and we can deep fake it too. So
Margaret, they frequently take my microphone away from me.
Recorded already, so whenever you want to start, it's all good.
okay, all right.
So Margaret, we can't see you in the camera,
Yeah,
so maybe you want to
you gotta-
jump in behind.
Well, I go behind
You-
Rich.
you
I'll
want
go behind
you want
Rich.
to scrub in? You want
That's
gown and
okay. I'll
gloves?
stand behind you, Rich.
Rich, why don't we get? Maybe we could get her to just get some scrubs on and stand
That's
next
right.
to you.
She has,
As long as
Yeah,
I don't
she's
do
there. She's
conservation.
right next to me.
No, this is good. I think it's great. Okay.
Jeff, you're not going to ask me the history or anything, are you?
Yeah.
No, I'm just gonna ask you what murmurs.
The first time Jeff and I worked together, he said to me, so did she have any murmur on physical? What's the history? And I'm looking at him like, what are you talking about?
Are you an
I
interventional
said, the only
cardiologist?
thing in this hospital that doesn't have VRE is my stethoscope.
So, Rich, you have to show her the famous Schlafmitz blood pressure picture.
Yes. Okay. So, okay, this is great.
All right, let's rock and
I
roll.
just want to get one LEO. Could you move the screens down a little, please?
Well, we can start, right?
They're going to start recording.
Yeah.
Yeah, no, but like give a little intro
I can
maybe.
start the intro.
Yeah, I think we should say OPC.
Yeah.
Who's on the panel?
So if you just want to do the intro.
Just myself, Ziad, and Jeff.
Okay.
Yeah, whenever you guys are ready for the intro, I'll give
Okay.
you a thumbs up
Here,
real quick.
okay. I can't see any thumbs, but. Okay. Well, welcome to another session of OPCI from St. Francis Hospital. And I'm happy to be here with my colleagues, Evan Schlafmitz and Ziad Ali. And we have a special treat today where we're inaugurating a brand new study in the United States called the EMPOWER study. And an additional pleasure is that besides Dr. Richie Schlafmitz doing this inaugural case, we have the global PI of it, Margaret McGendegard, who is here to really assist us and really explain to us the purpose of this study. And we're happy to throw it to her and have her introduce this exciting new venture.
Thanks, Jeff. And first of all, thanks to Richie, Ziad, yourself, and Evan for having me here today, and also for helping us really kickstart the study. So this is going to be the first patient enrolled in the study, and it's been fantastic how quick both Shockwave and St. Francis have been to help us get it off the ground. Hopefully Columbia and Yale will be close behind in the next week or two. So just to tell you a little bit about the background to the study. So there's large registry data that's shown for some time that atherectomy is associated with higher complications in women than in men. And after the Disrupt series of studies, Shockwave did a pooled analysis where they looked at the difference in gender and outcomes after Shockwave, and really reassuringly they found that the success rates and complication rates were exactly the same in men and women. So looking like Shockwave might be the safer option for calcium modification in women when we can use it. So off the back of that, and because there was only 20% of the trial patients were women, they decided to conduct this female-only single-arm study, essentially to recruit another 400 women to balance out the cohorts to confirm the initial findings that Shockwave appears to be both efficacious and safe in women with calcific disease. So as I said, there's going to be 400 patients. There's going to be up to 40 or 50 sites. Initially 2 rollouts in the US starting here today, and then some further sites in the UK and Europe. So in terms of outcomes, kind of primary outcomes of TLF, target lesion failure, and procedural success. So with that and with that background, I'll hand it over to Richie to show you the setup of this case we've got today, which I think is really a perfect first case for the trial.
So this is a patient who was referred to me. Physical, she had normal vital signs, 1/6 systolic murmur, otherwise unremarkable exam, and was having chest pain and had a nuclear stress showing anterior ischemia. So angiography showed a proximal AD lesion. Could you?
You got the slides up right now.
Oh, you
Yeah,
see
we
the slides?
see.
Okay.
Yeah, we see the diagnostic angio.
So she has calcium clearly on angiography. You could see calcium. But what I always tell people is that I'll pay you a mortgage for a year if you could tell me what's happening with the calcium inside an artery with an angiogram. So without imaging, certainly calcified lesions need to be imaged as far as I'm concerned. See if it's superficial, deep, or eruptive or nodular. And what Ziad Ali has pointed out is that nodular calcium is particularly disturbing in terms of MACE outcomes and treatment. We've come up with a whole treatment algorithm for the 3 different types of nodular calcium. So imaging is critical to do the right job and do it right the first time.
Yeah. So a couple other points about the trial that are important to make. So firstly, it's a all-comer female study in the sense that we're going to try and make it as real world as possible. So by that, what I mean is there's only really two key exclusion criteria. One is you've come in cardiogenic shock, and the second is that it's stent failure. But everything else can go in the study. So it doesn't matter lesion length, doesn't matter if you've got multiple vessels, doesn't matter if you're an NSTEMI or STEMI. So it's a kind of all-comers design. So I think that's particularly important. And the other thing that's important and quite deliberate in the study is, unlike DISRUPT, instead of needing to have tramline, severe calcium and angiography, or 270 in the imaging, we've said that if you have a case where you feel Shockwave is appropriate, you can put that patient in. And the reason we've done that is we want to capture the eccentrics and the nodules as well.
Okay. So we're going to do the OCT. Ready? And OCT literally takes us less than a minute to do it and to analyze it. Now, so when you see up on the OCT screen, so we do it manually so we can guarantee that our guide's in position and that there's no artifact with blood swirl. And that's when Rachel will then hit the start button. And you can see, when I see in the three-dimensional, the black screen, you see how black it is? There's no red. That's a perfect study. There is some red around that branch there. But we immediately can go to our MLA and see what our morphology looks like. So what I typically do is I go to the MLA, see them, and you see calcium there. So you see calcium from like 3 o'clock up around almost 9 o'clock. It's 180 degrees there. And we're going to scan and see the rest of the calcium here. You're going to go distally and proximally. We see we have a tight lesion. We have a nodule there at 3 o'clock. It's a not an eruptive nodule, but a nodule nevertheless. And we go proximally and look for landing zones. The key with angioplasty to me is landing zones, distal and proximal landing zones. If you have a good landing zone, you're going to get a great result. And the nice thing about the software with the Abbott OCT is I can, to a millimeter, pick my landing zone, 23 millimeters. I could pick the size so I don't underexpand. And I could see where the calcium is. So when I do Shockwave, I do pulse therapy. I have 80 pulses, and I want to use those pulses where the calcium is.
Yeah.
And the stent's 23, and there might not be calcium throughout that whole area.
Yeah.
So using co-registration, I can fix where the calcium is and do my shocks maximal.
So Rich, you'll be jealous. I was in London with Ziad this week, and we got to use the new catheter with 120 pulses, and really? I have to say it's fantastic to get that extra 40, especially in those long segments, you know, in the right and the LED.
Ziad, you were in London? You didn't tell me.
Sorry, Ziad, did I tell you?
No, that's okay. I don't get in trouble anymore.
Angiographically, someone who'd say, I already know there's calcium on the angiogram, I'm just going to go ahead, shock this, stent this, and we'll image at the end. I think most people would probably go with a 15 or 18 millimeter stent, and you see how the OCT really changes management, not just showing you the calcium morphology, but you could take appropriate length devices up front. We see it's actually a longer lesion.
So what percentage of the time does OCT change what a doctor does before or after a stent?
Yeah, I think we have good data showing, you know, with Light Lab, 9 out of 10 times it changes your management. That was done in the US, looking at decision making. In India, they did the exact same study, and same thing. It was 90% of the time it changes your management.
So Margaret, maybe you could talk to us about the eccentricity of the calcium and, you know, the relative impact of Shockwave in these cases.
Yeah.
And in the meantime, Craig Porter, can you turn on the device detection?
Well, actually, I have Susan. I have Susan over here. Susan is going to be Susan Thomas. She's our imaging expert. I'm here with Rachel and Poland over there. Hi, Diane. Jeremiah is not here, or else we'd have a full squad. But anyway, Susan, do you want to just show us some of that calcium there? Okay, so yeah. So she's basically, Susan's not Mike, but...
Wait there, I'll give her the mic for a minute.
No, so she's showing the nodular calcium at 3 o'clock. And then we're coming... I thought I saw one area of almost 270.
Nodular and eccentric. I would say this is more eccentric calcium because you're in the minimal lumen area. And Rich, I'm going to ask you to do me a favor. When you go in with the IVL balloon, can you do a dry cine with device detection before you inflate the balloon? That will highlight the eccentricity of the calcification, and then use your pulse therapy based on that.
Okay. So what
know you
Ziad
have
was saying,
device
Susan,
detection.
she's going to want to use device detection. So when we go up, we're all, Susan said she's on top of it. We all have it there. So she was just pointing out that there, it looks like this. The nice thing about OCT is you can also measure the depth of the calcium,
Yeah.
how thick it is, and this looks pretty thick. And 1-to-1, we picked the right size balloon for the vessel so we get the most impact of the shock wave.
Yeah.
All right.
Yeah.
So we're going to go with what size did you measure, Susan? 3.0. So we're going to go with the 3.0 shockwave. And we always measure with OCT after we shock to document fracture and also see if the vessel got bigger,
Yeah.
sort of like a girdle expanding, and the length changes if you have
Yeah.
a longitudinal split.
Yeah.
So we're going to go with the 3.0 shockwave. And the beauty of shockwave is that it's so easy, even a Democrat could do it.
Yeah.
Okay.
Yeah, so I like to image afterwards as well, Rich, because I think it also just gives you confidence to proceed on in the case and make sure you're going to get good stent expansion and a good long-term result for your patient. Coming back to the discussion about eccentric concentric, Z, so much like the kind of gender sub-analysis from Disrupt, it's also been a sub-analysis of the eccentric and nodular calcium that I know you've been very heavily involved with, and the papers are about to be published just now. But essentially, yeah, both you and Rich, and essentially the outcome of that has been that across whatever arc of calcium you're dealing with, that the shockwave has the same efficacy and safety. And I think that really kind of follows really what a lot of us have been doing in clinical practice. I think a lot of us have realized the device is very versatile with the different calcium morphologies. So it's nice to see confirmation of that.
Yeah. Well, one thing, Evan, the point of departure in terms of pre-imaging, by the way, I mean, what we find is your preconceived notion of the nature of the calcium is very frequently changed. And frankly, that you can downgrade your plans as well and not infrequently end up with a simple NC balloon in the face of it. So, and I've not been able to give you a predictive value from the angiogram of which OCTs actually turn out not to really need the advanced preparation.
And we were just talking about this actually during the calcium masterclass in London about how you can potentially determine whether or not this might be the case.
So Z, and also just if you want to point out the markers and the emitters, you can see it nicely on the, yeah.
I'm sorry, Rich, go ahead.
You go.
I was just going to talk about them being offset. So you'll notice that the first emitter is 4 millimeters from the distal balloon marker. Then there's a 6 millimeter gap to the next emitter, and then 2 millimeters. And the reason it's like that, one, is because Rich uses 30 frames per second, but also because the balloon is offset so that the front end of the balloon can deliver easily. So Rich, just take a dry cine for us there, and that'll highlight the eccentricity of the calcium. Stay on for 3 minutes. You see that on the bottom?
Yeah.
Just by the proximal emitter. So you're a little distal to the calcium. You can come back a little bit and save your pulses.
Okay. So we'll hook up now, and
you know, the other thing the baseline imaging does is it also lets you know if you can deliver the intravascular imaging catheter, you also know you're going to be able to deliver the shockwave balloon up front.
so the balloon inflated at 4. I'm going to give 10 pulses here, and you see the spikes, the paces spikes there, which don't cause any hemodynamic change. And I'm going to do 2 pulses here, and then I'll come back and do 2.
So just slightly changing the position of the emitters, Rich?
So I do if I'm doing a long lesion, but I have 80 pulses here. It's not really a long lesion, so I'm going to do 2 here and then 2 back.
Yeah.
Again, unfortunately, there's no algorithmic approach just yet as to what you do.
Yeah.
It's basically when we see the balloon go up fully, and if based on the calcium you saw before.
So do you see the shock topics that are on the screen now? The data shows that can give you about a 10 millimeter mercury drop in blood pressure, but no more than that. And it's not electrical energy, it's mechanical energy that's going through the heart that drops that pressure.
Yeah.
A little slow flow here. Go up. I just moved it back now.
But just a beautiful example of how easy it is to see the emitters here. and
You see
lining them
the-
up right across the calcium.
And how helpful device detection is. You're seeing good expansion here. We know we're getting good results.
So what's the contour of the pressure actually? With, if you sort of if you did a single contour of the pressure around that balloon in terms of the maximum pressure.
Well, it gets to about 50 when it hits the back wall of the artery, and then it turns backwards. That's the Spall stress, and then it drops to about 5 atmospheres.
Yeah.
So you should have around. There you go.
Oh,
That's
yeah.
the spot.
Yeah.
See the eccentric expansion of the balloon there now?
Yep.
And what you'll see here is on the device section, you can see a very subtle change, and usually that happens in the first several pulses. Where you see a very small indentation of the balloon pushing out towards the calcium.
And you see very clearly there as he had the wire hugging that eccentric plate.
Yep. Very
So
good.
Mark-
We've talked about this a lot, about how important that is. As long as that wire is hugging, that calcium is still not completely modified.
Right.
So I don't see it fully expanded.
No.
So
Correct.
would you go in now? Well, we're going to give a couple more shocks, but I'll just move this a little. But do you routinely go in with a high pressure balloon?
So like you, what I like to do is repeat my imaging and then make a decision, Rich, about whether I think that's necessary or not.
Well, just looking at this, usually I just image if I get full expansion, but looking at this,
Yeah.
I'm not confident that.
And then
I
and then
would-
one-to-one non-compliant.
Yeah, I would go with a 3.0 NC.
So
And look at it
Rich,
in
I
two
can-
views.
If I can indulge you on something that I started doing, once you've delivered your 80 pulses, I just use this balloon to go 18.
It doesn't
Right?
pop?
It's just a balloon. No, it's just a balloon then. And then you can see whether the cracked plate gets broken. And I would say 70% of the time you can determine whether or not you need anything else after that.
What's the compliance of the balloon?
I mean, its rated burst pressure, I think, is somewhere around that. But, if it bursts, I mean, it's not, I don't think it's I've never had one, by the way. I've never had it burst after you've cracked the calcium.
Yeah. So what's your vote? Should I image now and then decide on a balloon? What do you think?
I think that would be nice just
Okay.
to see.
So let's do that.
You used 70?
I use 70. I've saved 10 for a rainy day here. See what we got.
Yeah. It gets a refund. It's a 12% refund. And I think we should image at this point just to get the mechanism.
Yes, that's what we're going to do.
Yeah.
Just understand the mechanistic aspects of the non-complete expansion.
Good.
Because even though the balloon was eccentric, there was definitely an improvement in the lumen
Oh, the
as
lumen
the
is definitely
therapy
improved. Yeah. But
progressed.
my guess is we're going to have to balloon.
So just to talk about some of the new data with regards to fractures. So OCT misses 50% of the fractures compared to CT, micro CT. So, and that's because the tangential ray of light. So if you're not in the same plane as a light, you can actually miss the fractures. So when you compare it to CT, you can see 50% more fractures. 2 separate studies conducted at almost exactly the same time.
But when you do see fracture, it's predictive you're going to get adequate expansion. You may not always see the fracture, but it is very helpful. Once you identify
OCT,
the
please.
fracture, it's helpful.
Susan?
I'm actually very curious to see the effect on the calcium here.
Yeah.
I can't actually predict it.
Okay. Well, the vessel's open more, and I see fractures already. There's some fractures, dissection.
Section, yeah.
This section.
Oh,
Section.
Okay, well, that's,
you have a lot
There's a
of.
fracture.
yeah.
Yeah, the nodule
Yeah.
wasn't that a little, but
Yeah. Have a closer look at that.
Yeah. Is the vessel any
There's
bigger,
one
by
there
the way?
for sure.
yeah.
Yeah.
What's that?
So that's
Yeah, there's
It
one.
looks like it. Yeah.
Yeah.
What was that, Jeff?
No, the vessel, maybe it's the the vessel looks bigger to me too. I don't know what if
distally.
it's dilated.
I gave tritol, nitro.
Yeah, it's definitely bigger.
Oh, okay. All right. So I'm not imagining it.
That's another reason for us to measure again.
Yeah, especially in Prox LAD 3.0. It's a woman, but 3.0 maybe a little undersized. We'll see.
Well, we knew that from Illumian 3,
Mhm.
that the tighter your lesion, the more likely your vessel size is to change after you dilate.
Guys, you want to bring it in a little proximally where it's bigger, maybe around 12. The distal marker at 12. There's a
There's a
dissection.
dissection there. Yeah.
There's
Okay.
a small edge.
Got it. Okay, never mind. I'll be quiet.
Good.
So, Craig, yeah. No, go on.
So Susan, do you want to, I don't know if she can hear me, but do you want to zoom in on some of the fractures just to show the details of them after you give Rich a size and he can grab a stent?
So here's what's very interesting. The OCT is showing us that the inflow, the area at the ostomy of the LED is under 4.
Yeah.
So, you know, there's no way I was thinking about putting a stent back that far.
Yeah. Yeah.
So I totally changed what I'm putting in.
Yeah.
You know, if I eyeballed this before, I might have said a 275/15 with a 3.0 post.
Yes.
And now I'm going to a 2.538 with
Yeah.
a 3.0 post.
Yeah.
That
Yeah.
No, thank you, Craig. You could stay by the ostomy yourself. But
Yeah.
that's why I go to 7 French sheaths a lot, because I'm finding that you're right by a bifurcation. all
Yeah.
the
You
time
end
to
up
hear it.
converting into a much more complex procedure.
Thank you.
It's nice calcium fracture there.
Yeah. So
Do you want to point
Right,
that out?
so-
Yeah.
Mhm.
And the platelet aggregation there, the little
Mhm.
spot.
So what you see here is actually, if you can zoom in on that, I want to highlight something. So
That's a nice plate for.
what you'll see is that there's a tear at the interface between the fibrous and the calcific
Mhm.
tissue. And that's classically what happens in eccentric calcification. But remember, the fractures by IVL happen in every different plane, X, Y, Z, not just a single plane like with an NC balloon. So, Susan, can you just scroll through that and show us some of the fractures? So that's definitely, there's an intimal tear at, say, 6 o'clock, and at about 10 o'clock, that's actually a fracture.
Yeah, to me, the 6 o'clock looks like it could be a balloon effect.
That's what it
Yeah.
is. Absolutely. It's
That's
just
the-
tearing of the fibrous
Right.
interface.
Yeah.
Now, that was a fracture up at, like, say, 10 o'clock there.
We'll see post-stent if it's there. It could just be that.
So this is your 38 stent, Rich?
Yeah, it's a 2.538.
2.5. Okay.
And then we'll post with a 3.
Mhm.
My distal marker is on the co-registration screen right now. I'm a little behind that. Septobrand.
So you're aligning, we don't see the screen, you're aligning it with your
I'm
With OCT.
with your
with
OCT
OCT.
marker, right?
Yeah.
Yeah.
I think that's
Okay.
right. You see that?
Yeah.
septal
Looks
brand? You like
looks
that?
like it, Richard.
I'm just going to confirm in the LAO.
Mm.
Okay, go up to 12.
You can see that area, the moderate lesion in the prox there too.
Oh,
So that diagonal is something we could say goodbye to.
stem looks like it's expanded nicely, though, eh?
Yeah. We'll see well, when the balloon comes down, see what happens to the
Right.
contrast,
Yeah.
Rich. And maybe you'll say hello to it again.
No,
Or not.
I can
or
see.
not.
No, I didn't like that diagonal.
Is there any EKG changes or?
No.
No, not yet. But,
Do we have the, we play the original for us to?
So Jeff, let me ask you,
Yeah.
would you go get it?
That's what I want to say.
I think I
generally,
would.
yeah,
I
it's
think I
a
would.
big size vessel there.
It's
Generally, yes, I would do it. And certainly diameter I see from this, from the residual contrast makes it
I
big
think
enough.
so.
So let me
It
do
was
this.
right
Let
in
me
the middle of the
let me
Yeah.
post dilate, and then I'll go after the diagonal.
And if we go back through the last OCT, do we see it?
The ostium looked okay, I thought, on the OCT.
But that's where the eccentric lesion was.
There,
So
yeah.
Yeah.
basically,
That's exactly
the
where
physics are just to push it and squeeze the two edges of the carina. So this is a
Yeah.
classic carinal shift pinch.
And also you
right.
could see just distal to the stent, the high pressure balloon 3.0.
Can you press play on the OCT again? Just let it run through.
Yeah. I'll need another wire. The other thing is
Yeah, there.
you see the bridge
Yeah.
just distal to the stent
Yeah.
that Craig pointed out.
Yeah.
Thank you, Craig.
It is interesting how more manifest the bridges are after the stent.
Yeah.
It creates a little hyperemia, creates a little vasodilation.
It's
The
contrast
contrast
cleared.
dissipates,
It's
so
cleared,
there's
yeah.
something-
Yeah.
Yeah.
exactly. So a little nitro there may be good too.
Yeah.
But I think doing ballooning first is important because in a sense, this is a pot because this is
Yeah.
undersized for that area. So if you really want to access the vessel, this will give you a better opportunity by spreading the struts, obviously,
Yeah.
and maybe even indenting a little bit into the ostium and clearing the way.
Well, yeah.
How high are you going, Rich?
Where it wasn't calcified, I was only going to 12 with the 3.0. Where it's calcified, I'm going to go to 18. I just want to line it up.
Mm-hmm.
What? $18. So I'm going to 18 now.
That's expanding well.
That looks nice.
Yeah.
I mean, it's not the same view, but
Well, we'll OCT and see
Mhm.
where we are.
Well, that's the beauty of not having to take a lot of pictures. OCT.
Yeah.
Just having a three-dimensional reconstruction has its advantages.
Yeah, still no contrast in the.
Mm-hmm.
I'll fix that in a second.
It's
Oh,
there.
Slow.
Yeah.
There you go.
Yeah.
Let's get that.
Uh-huh.
What's that? I'm sorry, I didn't hear you guys.
No, we're good. It's Timmy 3 flow.
Yeah.
Yeah.
Stent looks expanded as well, yeah, angiographically.
The LED looks
Terrific.
Yeah.
okay. I mean, it still has the inferior border is not perfect, but let's OCT and see.
Yeah.
I think it's a step up, step down. Looks good.
Yeah, and
so
it'll
I
be
think
good
we're gonna
then.
have a good lumen. I try to always tell my colleagues the idea of a stent is to make every line perfectly straight.
Yeah.
Colonizing the artery.
It's the lumen that we really do.
Colonizing the.
Miss Mike. Let's just put one more stent. A 38?
All right.
So how many OCT runs did we do so far?
2.
2, and this is the 3rd. But, for anyone who's watching, I mean, how long does it take to do this? And
Yeah.
it lets you know where you are. It takes any kind of mystery out of what you're doing.
Exactly.
Yeah. But it's also the trade-off. I mean, it's prescriptive immediately. You're not hunting around for device sizes. You know precisely what you need. From
Yeah.
the staff standpoint, it makes their life much easier.
Yeah.
You get the optimal procedure strategy. And that's what in Disrupt CAD 3, they looked at that. There was the OCT sub-study compared to the non-OCT arm, 3 OCT run minimum, and there was no difference in time. You actually saved 2 minutes. It was not
But
statistically
it was
significant.
80%
Diagonal
of
looks good.
resources.
Oh, that's
We don't
good.
mention that part. Yeah. But it doesn't
That's
it
good,
doesn't have
yeah.
to significantly add to the time of the procedure, even with 3 runs.
So
So
we're
distally, we're good.
yeah. We're
So
having the
distally, no edge
OC.
dissection. Apposition's great. Expansion looks
Looks
good.
good. Yeah.
See some calcium
Areas
fractures
are gonna be
again.
good.
I defy you to show me where the eccentricity was.
A little dissection proximally.
And yeah,
It's
tiny,
tiny.
very,
Yeah.
very small
Yeah.
arc. That's not gonna
Yeah.
No, it looks
cause
good,
any
though.
issue. That's gonna heal well.
Luminal gain is good. Apposition is good.
Over
What is the
100%
diagonal?
expansion.
What does the diagonal look like?
You can see it. It's at 38. Go to 38. See that little dent? That's what it's missing.
Yeah. There.
Right there.
Yeah.
Yeah, okay.
So we're having an OCT sub-study as part of EMPOWER. So 50% of the patients, hopefully, and of course, Rich, I'm sure you're gonna you're gonna populate that.
Just, go to that. I just want to demonstrate something on the OCT, which is important. Go to 38, please. Okay, a couple things here. So one, you see the OCT is not automatically detecting the branch, and so that's why you're not getting the red marker. But you see that flap that's over it?
Yeah.
That's the carina shift.
Yeah.
So you rarely get to see it. So it's a very, very tight, very, very focal 1 or 2 millimeter lesion, which is why we remodified it by expanding with the NC, like Jeff said.
Yeah.
Okay.
Do you guys want to just to finish off, just talk through why it's okay to leave that edge dissection for anybody who's watching, to make them confident it's okay to leave that?
The proximal one, you mean?
Yeah.
Well, one thing is right after the dissection, you have the stent, so it's not going to propagate
Yeah.
anywhere. It's not into the media. There's
Yeah.
not a flap 90 degrees. It doesn't
Yeah.
extend 5 millimeters. So
Exactly.
I think we're okay with that.
Exactly.
So a lot of times people will say to me, OCT gives you too much information. It just gives you the right amount of information so you can make an intelligent decision.
Yeah.
So the data from this comes from the CLIO PCI study from Francisco Prati. 4.5 millimeters squared area at the distal reference was an independent predictor of target lesion failure in MACE, but at the proximal reference not, because of the reason Rich just mentioned, which is you've basically created a rent and you can't create an intramural hematoma. And then we use the 60 degrees, which actually comes from ADAPT-ES, which was 59 degrees and 3 millimeters was an independent predictor for stent thrombosis.
Yeah.
You also see where it's located. It's not extending into the diagonal either. So this is likely to heal very well on its own.
Yeah.
Yeah. Well,
So-
I mean, when we initiated this, we did have problems with it. People were over treating. It got rationalized over time, and now you're using pretty much the same criteria as we use with IVUS.
But perfect. No, small medial edge dissection, apposition 100%, 100% expansion. Hard to argue with that.
So, Rich, fantastic result in the first case in the study. Thank you so much to you and your team for doing it so efficiently and so elegantly.
Are you going to come down for the next 60? Are you doing anything in the next 2 weeks?
We're delighted to have you on board, and thanks for your support.
No, it's a pleasure.
So,
Any final comments from the panel? You happy?
I think just to add that severe calcified lesion prep with IVL, we have 3 OCT runs. This is a live case with some discussion. It's all done in under an hour.
Yeah.
So I think for everyone's practice at home, can't say you don't have enough time to incorporate intravascular imaging to your procedural optimization.
and congratulations, Rich, and thank you, Margaret, and congratulations to you for inaugurating this study, which I'm sure we're going to have a wealth of data emerging from over the next couple of years.
Absolutely.
Well, I just got to take my orthogonal views here so I don't get any,
Any protocol breaches?
We were going to force you to go get the diag because we don't want a peri-procedural MI for your first case. So I know it was going through your head, Margaret.
You want me to do that?
Liz Gates.
Beautiful. That's great.
Okay. All right. So thank you all for joining us for another episode of OPCI, and I want to thank my colleagues here for propelling a very interesting discussion, and hope to see you again soon.
Perfect.
You guys good?
Fantastic.
Yeah, awesome. Really good.
Everybody.
Time
Great.
for I thought, do you want to just fit another one in, Rich? We got another
Sure.
30 minutes.
Yeah. Have someone on the table next door. We'll go do it. Thanks, guys.
Good. Awesome.
Great.
Thanks,
Look at
Rich.
that.
Brilliant.
Three imaging runs, perfect result, 30 minutes, IVL. I mean, like,
It's great. And we're going, table time for you is
1:15. So we're going to start at 2.
Recording stopped.
But we'll get everything.
Are you